Having discussed the acute leukemias, let us move forward and talk about the chronic leukemias. Now, well, you know, I've entered into chronic means now no more talking about blasts, guys. We are not going to talk about any kind of blast. All the blasts have vanished. Now we are into chronic leukemias. The first one is CLL, that is chronic lymphocytic leukemia, which means that I'm going to have lymphocytes, not blasts. That's the rule. But you know, this leukemia in a lot of ways is a leukemia of exception. I'll tell you how. Number one, this is the only leukemia or the only one in this entire series which is not associated with radiation. The only leukemia not associated with radiation is going to be CLL. Number two, in everyone or ALL, AML, even going forward in CML, everywhere I will teach you some translocation. Translocation 922, translocation 1517, translocation 1221. Everywhere I will talk about a translocation. But here, the most common genetic alteration is a deletion. It is not a translocation. It is deletion 13q. So these two exceptions make it very, very different. Also, the age group of this is very important. It is the most common leukemia that you see in elderly. So you will usually start off with a 65 or a 70-year-old man. And this is also the most common leukemia in the West. In the Western population, it's the most common leukemia. So repeating, this is the only leukemia not associated with radiation. This has been a very important question even in your neoplasia chapter. It has a deletion 13q. It is very common in elderly. It's very common in the West. That is chronic lymphocytic leukemia. Let me tell you about its clinical features and criteria. So as I said, you are always going to have some or the other elderly patient. There is going to be an elderly patient, point number one. And the earliest finding, actually when you listen to the earliest finding, it will be a little vague because the earliest clinical finding is tiredness, fatigue. The earliest clinical presentation is fatigue. So imagine a 70-year-old man coming to you and saying that he's feeling tired. That is going to be such a vague, a non-specific kind of a symptom. Will you be able to pick it up only on the basis of having fatigue in an old person? No. So obviously, this is not picked up at a very early stage because of this. But following that, yeah. Can it show you other features such as lymphadenopathy, such as hepatosplenomegaly, organ involvement? All of that is possible. So first, let me tell you the diagnostic criteria, and then we'll go ahead and talk about the different transformations and how it will progress. So when I'm talking about the diagnostic criteria, we always say that there are a total of 3 things that you need to know, and all 3 diagnostic criteria have to be met. Firstly, the absolute lymphocyte count. So before that, many students just read these criteria and these numbers and they really don't bother about what sample am I taking from the patient. So if I take a blood sample from the patient, on a blood sample, if I want to find out the lymphocyte count, absolute lymphocyte count is what I want to find out. Absolute lymphocyte count is going to be more than 5,000 per mm cube. Absolute lymphocyte count more than 5,000 per mm cube. That's on the blood. Then you'll go to the bone marrow. In the bone marrow, the lymphocyte count is going to be more than 30%. The lymphocyte count shall be more than 30%. And let me tell you again and again, keep focusing chronic lymphocytic leukemia. So all that I'm talking about is lymphocyte. In bone marrow also I'm talking about the lymphocyte. And finally, you are supposed to document CD5 positivity and CD23 positivity both. Remember, that's the rule. You have to go ahead with a dual positivity. And how do you check that? What is the technique? Flow cytometry. Whenever I have to check up on CD markers, I'm going to do a flow cytometry. So on that note, repeating once again, you take a blood sample, the lymphocyte count should be more than 5,000. You take a bone marrow, lymphocyte should be more than 30%. And both CD5 and 23 dual have to be positive, and that is what you understand by flow cytometry. You understand that by flow cytometry. For that matter, although it's not a part of a criteria, but definitely there has been a new marker, and that new marker is CD200, which has been a previous year question also. CD200 is found to be positive in CLL. Another thing which is important but is not a part of the criteria is your favorite cell. I know all of you have seen this and immediately given me an answer of a smudge cell. So guys, look at this. These are lymphocytes. These are the tumor cells. These are lymphocytes, proper round lymphocytes. But suddenly I realize they are smudged out, as if ink has been smudged out. So these are referred to as smudge cells. But now smudge cells have a different shape. Like, see, they're smudged in. If you take a drop of ink and you smudge it, it'll all be in various shapes. Some people said it's looking like a parachute. Then some people said that no, it's looking like a basket. So basically, it looks like a parachute cell. It looks like a basket cell. These are the different names of a smudge cell. So there are 2-3 very important questions of a smudge cell that are found. Number one, smudge cells are seen in which situation? And as soon as I say smudge cells, everyone answers CLL. But no, guys, smudge cells are non-specific. They can be seen in ALL also. They can be seen in infections like infectious mononucleosis. So basic point is that smudge cell is a non-specific. That is the reason now you understand that we did not include this in the criteria. No, it's not a part of that 1, 2, 3 criteria. Nowhere did I mention smudge cell. It's an additional finding. Point number 1. Question number 2. What is the pathogenesis? Why are cells breaking? So firstly, this is not inside the patient's body. Don't feel that you have a case of CLL and inside his body these broken cells are roaming around. No. In his body, proper round formed lymphocytes are roaming around. This I have made. When I made a smear, when I put pressure and I make a smear, I have ended up making this. So this is a smearing artifact. The pathologist ends up making this. This is a smearing artifact. So why? I make a smear of every drop of blood in the lab, okay? Only these are breaking. Why are other cells not breaking? Something must be weak in them. Yes, smearing artifact due to what? There is a loss of a very important molecule called vimentin. You know, vimentin is like that backbone of a cell. If vimentin is there, cell feels very strong. When the vimentin will go away, cell will break off. So that vimentin has gone, the backbone of the cell has gone. That is why the cell is breaking, and this is referred to as the cytoskeletal theory. This is referred to as the cytoskeletal theory. So please remember, question number 1, smudge cell has been given a lot of other names like parachute and basket cells. They are non-specific. They can be seen in any kind of lymphoid origin disorder, and they are a loss of vimentin. They are a smearing artifact. That wraps up your CLL diagnostic criteria and additional findings. But what about the origin and what about the genetics? Let's go ahead. When I'm talking about CLL, please remember there's a list of genetics that you have to know, and then also the origin, which I'll tell you in a while. So first, let me tell you the most common genetics was what? Deletion 13q. There's another odd number that is deleted. There can be deletion 17p also. Deletion 17p. What is 17? Policeman, P53. That can also be deleted. Other than that, we can also have trisomy of chromosome number 12. These are some of the genetics that you have over here. But all in all, another thing that has been noted is this most common one has a little bit of a different pathogenesis, which is very interesting. And the same pathogenesis I have taught you in the genetics chapter. When I say deletion 13q, I'll draw chromosome 13 for all of you. For example, if this is chromosome 13, this is the short arm of chromosome 13 and this is the long arm of chromosome 13. You are saying 13q is getting deleted, the long arm is getting deleted, the entire arm doesn't get deleted. There's a portion of the arm that gets deleted, and this portion, I'll draw 2 colors. These portions are deleted. You know what are these? These are microRNA 15 and microRNA 16. What is actually deleted is microRNA 15 and 16. So when I say that 13q is deleted, in other words, I say microRNA 15 and 16 are deleted, and that is the reason that CLL occurs. Actually, it's a microRNA deletion defect, microRNA 15 and 16. Also, another enzymatic activity that is a defect in cases of, or can be elevated in cases of CLL. Please remember there is a Bruton tyrosine kinase mutation also that can be noted. Bruton tyrosine kinase mutation has been noted. Guys, can you think of two disorders in the entire pathology? One is CLL, but anywhere else, the name is only telling you Bruton tyrosine kinase. Which other disease was having the name Bruton? This defect is also seen in Bruton's hypogammaglobulinemia. Bruton's hypogammaglobulinemia also shows you the same. So repeating, it's most commonly showing you deletion 13q, and that deletion 13 is actually a deletion of the two microRNAs 15 and 16. There are other deletions and trisomies known, but there's also a BTK mutation that is known. Genetics is done, criteria is done. Moving forward, what all can this CLL patient transform into? So before I go into transformation, let's look at a simple plain CLL slide which I showed you a while ago. Did I show you plain CLL slide is nothing but one cell? Lymphocyte, 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 lymphocyte. No other cell, no blast, no other cell I'm talking about. Only one cell. Means everyone is wearing a uniform. Everyone is looking like the same person. Everyone is looking like the convent school girl. Why do we say convent school girl appearance? Because everyone in school, everyone wears a uniform, right? And that uniform looks exactly the same. So when we say convent school girl appearance, it's basically the concept being that you are going to signify lymphocyte, lymphocyte, lymphocyte. So till the time it is only lymphocytes, it's a plain CLL. But now the lymphocyte is going to transform. And what is that transformation? So have a look at this. This CLL is what kind of a disorder? It's a white blood cell disorder. I say along with this CLL now, if the red blood cells also get affected, what red blood cell etiology will it have? Warm autoimmune hemolytic anemia. Warm autoimmune hemolytic anemia also happens, and along with that, a platelet problem also happens. Immune thrombocytopenic purpura. Immune thrombocytopenic purpura means platelet count also goes down. The RBCs are also gone, and WBC mein to problem hai. So what is this transformation known as, guys? Imagine RBC gone, WBC gone, platelet gone. Everyone is gone. When everyone is gone, you call it Evans syndrome. When everyone is gone, you call it Evans syndrome. So repeating, Evans is everyone. That is how I have learnt it. Evans is everyone. That is, when RBC, WBC and platelet, everyone is gone, that is going to be Evans. Coming to the next, another transformation is possible. CLL, what kind of a cancer is it? Blood cancer, chronic lymphocytic leukemia, blood cancer. But didn't I tell you in the first part, at any point of time, leukemia can change to lymphoma? Can CLL become a lymphoma? When CLL becomes a lymphoma, it is known as the small lymphocytic lymphoma. It is known as the small lymphocytic lymphoma. So CLL from the blood goes into the lymph node. It's a small lymphoma. But now I say that this small lymphoma transforms into a big lymphoma, DLBCL. That is diffuse large B-cell lymphoma. Diffuse large B-cell lymphoma is what it transforms into. So can I say from a small cell lymphoma, it has changed into a large lymphoma, and this syndrome or this transformation is known as the Richter's syndrome. This is referred to as the Richter's syndrome. So how I have learnt it is, chota admi has become bada admi, rich. A person has become rich. When does a person become? When a person becomes rich, you say from chota admi, he has become a big person. From a small person, he's become a big person. That is when he becomes rich. So now see, the transformations are so simple. Number one, Evans syndrome, and everyone is affected. RBC, WBC, platelet. And what is Richter syndrome? Rich. When small lymphoma has become a large lymphoma, it's become rich. That is what you see in CLL. But right now I told you, CLL changes into a lymphoma. Do you want to see that situation under the microscope? A lymph node under the microscope? Have a look at this, guys. First and foremost, this is a normal lymph node, because very few times do students focus on normal lymph node. And then this is a CLL, SLL lymph node with which it has been affected. So first and foremost, if you look at a normal lymph node, you will see that there is some dark lymphocytes at the periphery. there are dark lymphocytes, and then there's a very light center. That light center is known as germinal center. So at the periphery, you have all the lymphocytes, and in the center, you have activated cells or germinal centers. So you will see that. You will see that in a lot of places. The periphery is darker, and then in the center, you have a germinal center. Periphery is darker, the center has a germinal center. So that is said to be the follicular pattern. That is, the normal follicles, normal lymphoid follicles are going to look like this. There is a germinal center over here, normal lymphoid follicles. But what do I see in CLL? I don't see that normal lymphoid follicles, but what do I see? Lots and lots of lymphocytes. Lots and lots of lymphocytes, because it is chronic lymphocytic leukemia or lymphocytic lymphoma. So there are lots and lots of lymphocytes and some activated lymphocytes. Along with that, there are going to be some activated lymphocytes also, and those activated lymphocytes are known as proliferation centers. So actually this is not that germinal center and all, but yeah, some centers are being formed. So if I try and look at this carefully over here also, I can definitely see that there is a periphery that is looking a little darker and the center is looking a little lighter. See, the periphery is looking a little darker and the center is looking lighter. So is this a real follicular pattern? No. But is it a pseudo follicular pattern? Yes. This is a pseudo follicular pattern. It is not looking like the normal lymphoid cells. No. It is not looking like the normal cells. It's not like a normal proper follicle with a germinal center. But because these cells are proliferating, because it is forming a lymphoma, lymphocytes with proliferation centers makes it a pseudo follicular pattern. Coming to the last part, that is how to do the prognosis of this particular lesion. So remember, when we're talking about CLL, the origin is one of the prognostic features. So in terms of origin, has it originated from an innocent B cell, a naive B cell, or has it originated from a post-germinal center B cell? Repeating, has it originated from a naive B cell or a post-germinal center B cell? That will make a difference. So naive B cell is poor. See, naive is innocent. Being innocent in today's world is really bad. If it's originating from the naive B cells, it is very, very bad. If it is originating after germinal center, that is good. Now, what is the most important two microRNAs that you studied? MicroRNA 15 and 16, thankfully they belong to the good prognosis. They belong to the good prognosis, and after that whatever will be written, by chance they start showing you CD38, by chance they start showing you notch mutation, they show you ZAP70, or they show you elevation of beta-2 microglobulin, all of that comes under the wrong variety. So repeating once again, only see, being innocent is very bad in today's date. Anyone will make a fool out of you. So being innocent is bad. Arising from innocent B cell is bad. Arising from post-germinal B cell is going to be good, from a post-germinal center. Also, the deletion 13q, the microRNA 15-16 story is good. Rest anything else mentioned in the exam is going to be bad. Before we end, we must also know that what are the two stagings that we follow for CLL? There is something known as a Rye staging and a Binet staging. Rye and Binet, you can see Rye is going into 0, 1, 2, 3, 4. Binet is going into ABC. You don't have to learn these stagings. First thing that I want to break to all of you, you just need to know that there is something called a Rye and Binet staging. And obviously, it's a staging for what? For that you will mug up. It's a staging that you do for CLL, right? It's a staging that you do for CLL. So it's primarily a lymphocyte disorder. But apart from lymphocyte, in which stage are RBCs and platelets affected? In which stages are RBCs and platelets affected? I have realized in the topmost advanced stage of both Rye and Binet. So in Binet, it is going to be seen on stage C. And in Rye, it is seen in the higher stages like 3 and 4. So basic point is, when do we see anemia and thrombocytopenia? You see them on the higher stages. That is stage 3 and 3, 4 and C. That is Rye and Binet staging. We have wrapped up our discussion of CLL and we can definitely have one or two questions. One of the following leukemia almost never develops after radiation. I just told you CLL was the leukemia of exceptions. It is never ever going to develop after radiation. Next question. Here you have a 72-year-old man with a known case of CLL presents with a new finding of a 3 centimeter cervical lymph node. So some lymphoma must have happened. CLL coming with lymph node. Has it changed into a small lymphocytic lymphoma? Let me read. On FNSE, the lymph node shows the appearance of large. No, it's not small. They are not saying small lymphocytic lymphoma. They are saying large pleomorphic cells with nucleoli and lot of mitosis. This is not sounding like a small lymphoma at all. This is sounding like a large lymphoma, that is DLBCL, diffuse large B-cell lymphoma. What transformation are they trying to mention over here? Small becoming big. This must be a case of Richter syndrome. This must be a case of Richter syndrome. So yes, CLL progression I could understand. I would have selected it if Richter's wouldn't have been in the option. Here Richter's is clearly there in the option. So I will obviously mark Richter syndrome when SLL changes to DLBCL. CLL is done for us. We are now left with the last leukemia, and that is the chronic myeloid leukemia. But the best part is that by the time you come to chronic myeloid leukemia, half of the battle is won and you have studied almost everything about it. So there are 2 points that you have to start off with, that is the genetics and the clinical symptoms, and then we have certain pathology findings. So when I talk about the genetics of CML, when I talk about CML, chronic myeloid leukemia, there's a very famous genetics that everyone knows, and that is translocation 922, right? The Philadelphia. So let us draw it out. Here you have chromosome 9 in front of you, and here we have chromosome number 22. And let's draw the normal. What does normal chromosome 9 have? Normal chromosome 9 has ABL, and normal chromosome 22 has BCR. But now I'm saying there's a translocation, means this ABL has gone and sat over here. So here you have the ABL and here you have the BCR. Has there been a BCR-ABL fusion? Because of this BCR-ABL fusion, there is an increase in which activity? There's an increase in the tyrosine kinase activity, and that is going to result in CML. So translocation 922, the ABL came and sat with BCR. So ultimately I want to ask you, both the fusion proteins are sitting on which chromosome? Both the fusion proteins are sitting on chromosome 22. So now when you say that 922 is known as Philadelphia chromosome, I hope everyone is aware and is understanding that Philadelphia chromosome is not the entire translocation 922. No, Philadelphia chromosome is just this chromosome where the fusion of the proteins has occurred. Means chromosome 22 should be defined alone as the Philadelphia chromosome. I hope you know this concept. Whatever may be the fusion, tyrosine kinase activity increased and patient developed CML, as a result of which whenever I will have to do the treatment of CML, I will block this tyrosine kinase. I will give tyrosine kinase inhibitors. I can't do anything about Philadelphia chromosome. That has happened. But I can control this tyrosine kinase activity, and for that we are going to go ahead and give it imatinib. We are going to go ahead and give imatinib for the treatment of CML. What does imatinib do? Imatinib blocks the tyrosine kinase levels. Now, apart from this, I was telling you some time ago that BCR-ABL fusion that occurs because of translocation 9 and 22 every time doesn't result in the formation of CML. It results in something else also. Remember that? And I told you, you will first go in the exam and write L, M, N in this order. You will write L, M and N because that will tell you that this can result in ALL also, this can result in CML also, this can result in CNL also. Write it in an alphabetical order and then write that depends on the weight of BCR-ABL fusion. If it is 190 kilodalton, plus 20 means 210 kilodalton, plus 20 means 230 kilodalton. That's why I said go in 20, 20, 20 and write it in an order. So ALL can occur, CML can occur and CNL can occur. These are the three things that can occur because of it. But tell me, when this occurs in CML, I am associating it with a good prognosis. But when this is occurring in ALL, I am saying it is having a bad prognosis. Why is that so? Because I told you a rule that lesser will be the weight of the fusion protein, more will be the tyrosine kinase activity. It goes opposite. Lesser the weight, repeating, the weight and the tyrosine kinase activity are inversely proportional. So you can say the least weight was there in ALL, that is why it's got the maximum tyrosine kinase activity, it's got the worst prognosis. Because the weight is the least, this means the tyrosine activity is the most. That is about BCR-ABL. So now if I have to test for this, If I have to test for translocation 922, what is it that I'm going to do? For CML, what is going to be the investigation of choice? We are going to do a fish. And what do we do for fish? You know, there'll be a color coding. Color coding examiner gives you, always I tell you. So over here, clear cut, they have told you that I'll write it up in bold. ABL has been given a red color. BCR has been given a green color. So everywhere, ideally, every patient, every person has chromosome 9, 2 copies, chromosome 22, 2 copies. So 2 ABLs, 2 BCR. 2 red colors should be seen. 2 green colors should be seen. Perfect. This is fine. 2 red colors, 2 green colors. But suddenly here, I saw only 1 red color and 1 green color. Where is the other red and the other green? They have gone and fused. And when red and green fuse, they result in the formation of yellow. I can see the red and green are fusing over here to form a yellow. This is showing me translocation 922, or this is showing you the BCR and ABL fusing. Look around into all the others. Here also you can see something yellow that is fusing. Look around over here. You can also see there is yellow. There is something yellow that is going to be fusing over here. So whenever you see this kind of a fusion, you are dealing with fish. This is translocation 922. When they fuse, you will see a yellow color. Finally, your entire work of CML is done. You will see a Philadelphia chromosome, but do you know what will that result in? So most of you think that 922 Philadelphia chromosome, CML is a WBC disorder, only WBCs will have a problem. No, remember, this is going to happen in the stem cells. So this is going to affect all the lineages, just not the white blood cells. Even the red blood cells are affected, even the platelets are affected. So first let me have a look at the white blood cell picture. This is how CML looks like. CML shows you, firstly, it's a leukemia. So the WBC count is of course going to be very, very high. But apart from that, you can also visualize that so many cells are there. Let's try and identify. I can see a neutrophil over here. I can see a neutrophil over here. Then I can see a cell which has a slightly indented nucleus. What was that? The one looking like metamyelocyte. This must be metamyelocyte. Then I can see there's a cell with a D-shaped nucleus. So D-shaped nucleus must be myelocyte. Myelocyte is D-shaped. Then again I can see a neutrophil. Then I can see some orange cell. Orange cell must be an eosinophil. Again I see an M-shaped cell, means this must be a metamyelocyte. Okay, so I can all in all see a lot of cells, and can I say there is something known as shift to the left. There is shift to left. What do I mean by shift to left? I'm going to take you all the way back to the first slide that I taught you in this chapter. And do you all remember this slide of myelopoiesis? Do you remember how myeloblast gave promyelocyte, myelocyte, metamyelocyte, band form and neutrophil? You remember that? When I say that I'm only and only seeing neutrophils, that is normal. But when I say shift to left, means opposite. I'm seeing band form also, metamyelo also, myelo also, promyelo also, and blast also. Shift to left means all the immature forms. All the immature forms are going to be noted. That is said to be shift to the left. Along with that, are you seeing eosinophils as well? Because yes, eosinophils can be seen. For that matter, CML is very famous for showing you basophils also. The only leukemia where you study basophils are going to be CML. So CML shows you a shift to left, lots of cells. And please remember, in the bone marrow, you can also see something known as pseudo-Gaucher cells. You also see the presence of pseudo-Gaucher cells. That is what CML shows you. So now coming to your clinical features. Now let's start from a patient. You will usually have an adult patient who is coming to you with a dragging sensation in the abdomen. I'm going to now club and make a story for CML for all of you. Dragging sensation in the abdomen is what this person is going to tell you. As soon as a patient tells you dragging sensation in the abdomen, what you think of is going to be a massive splenomegaly. What you think of is going to be a massive splenomegaly. That is a massive spleen. So he says, someone pulling my abdomen down. Something is pulling my abdomen down. Fine. Then you go ahead. You do a peripheral smear. On a peripheral smear, you see shift to left. Along with shift to left, you're seeing a lot of basophils. What is the leukemia that you started suspecting? What did you start suspecting? You started suspecting CML, but now the next question is, which phase of CML is this person in? Till here the story is fine, but which phase of CML is this person in? So remember, CML has 3 phases called the CAB phases. What are CAB phases? Means there's something known as a chronic phase, then there's an accelerated phase, and then there is a blast crisis. Repeating, what are the CAB phases, guys? There's a chronic phase, there's an accelerated phase, and then there is a blast crisis. So I always say CML has CAB phases. Okay. The first criteria for these is blast count. Chronic leukemia, blast count should be less than 20. Everyone remembers that basic? So in chronic phase, there is less than 10% blasts. In accelerated, accelerate the car a little, take it forward, 10 to 19% blast. See, I'm still keeping it under 20%. That was my rule, that was my promise. It has to be under 20%, it is. But when we go to blast crisis, it is equal to or more than 20% blasts. That is why I say that it has gone into a crisis. And not only are there more blasts in the blood, but there's also outside the marrow, there is extramedullary blast proliferation. It's a blast in the entire body. Extramedullary blast proliferation is what is noted in blast crisis, and let me tell you, those blasts are usually of AML than ALL. Very important to know that CML usually transforms into which, so obviously, why am I saying AML suddenly? Because the blast count has crossed to 20%. As soon as the blast count will cross a 20%, I'm no longer in chronic. I cannot call it CML. I will have to say CML that has changed into either an AML or an ALL. If it's a myeloblast, then it is AML. If it's a lymphoblast, it is ALL. But more chances are that CML will go into AML. That's the blast crisis where the story has only changed. But what are the other two? So you have to look at the blast count in the exam. Less than 10%, 10 to 19%, or 20 or more than 20%. But after that, there are a lot of criteria that also go in the accelerated phase. That is, if they say that the basophil count is more than 20%, the basophil count is more than 20%, if they say that there is no response to treatment, means the spleen size is increasing, I'm giving treatment. What treatment? What drug do we give? Imatinib. I'm giving treatment, patient is not responding. Number 2, the total leukocyte count is very, very high, or the total leukocyte count is very, very low. Or in other words, the platelet count is very, very high, or the platelet count is very, very low, and nothing of this is responding to treatment. It is non-responsive to imatinib or to the treatment. TLC very high, very low, platelet very high, very low, or the spleen is not improving, massive spleen is remaining as it is, patient is not responding. Or last thing, there are some additional chromosomal problems. There are some additional cytogenetics that has come up. What is that additional cytogenetics? See, one cytogenetics was anyway there. Translocation 922 was anyway there. But additional cytogenetics means isochromosome 17q and trisomy 8. These two, actually there's a long list, but these two are the most important. Isochromosome 17q and trisomy 8. Additionally, if they come up, this means the car is accelerating. The car is going forward. So repeating once again. Ultimately, I realize the 3 differences between them are going to be on the basis of the blast count. When I talk about the blast count, it is first CAB phase, chronic accelerated blast, less than 10, 10 to 19, more than 20. That is the first thing. After this, you need to know that all the other things are put in accelerated phase, whether it's the basophil count or the spleen or the TLC or the platelet or the cytogenetics. Everything is in accelerated, but now, word of caution. In the exam, you guys are in too much of a hurry and you just read 20%, 20%. But what 20% you have to read? If they say blast is more than 20%, it goes into blast crisis. But if they say basophil is more than 20%, that goes into the accelerated phase. So you don't have to falter over there. You have to make sure that you've read the question carefully. Now, obviously, you need to know the treatment, which I have already told you that you are going to give a tyrosine kinase inhibitor, and that is imatinib. Most of the patients respond to imatinib. If they are not showing you a response to imatinib, which phase are they coming under? They are coming into the accelerated phase. And what will you see? All these features of accelerated, including the basophils. You're also going to see the basophils over here, right? So can I say, going all the way back, that these patients were showing you blasts, they're showing you basophils, they're showing you myelocyte, metamyelocyte, full shift to left. Can I call this as the very, very famous garden party appearance? Either you call it garden party or you call it college girl appearance, because these are the two very famous questions that examiners ask you. What is garden party appearance or college girl appearance? Everyone is dressed beautifully differently. Like you go to college, you don't have any uniform, you all wear different clothes every day. Or you go for a party, you all wear beautiful, pretty clothes. So I don't know why only girl appearances are there, but it's applicable to boys also. So on that note, please learn that whether you're talking about CML or CLL, there are two very, very important, you can say two very, very important points that I want you to note over here. Two dabba of time. Dabba time is table time. So when we are talking about CLL versus CML, CLL had only lymphocytes. Everyone was wearing the same uniform. That was convent school girl appearance. Whereas CML, everyone is looking shift to left, basophils, eosinophils, all different kind of cells are there. So we have the college girl or the garden party appearance. College girl or the garden party appearance. That's one dabba. The second dabba that I want all of you to make. Where else in medicine or surgery do you guys use imatinib? Imatinib questions are very, very important. So firstly, imatinib is used in CML, but it's also used for a stomach tumor called gastrointestinal stromal tumor. So whenever you want to do tyrosine kinase inhibition, you use imatinib, two tumors, CML and GIST. These are the two dabbas that you had to make. One more. Is there anything that you can confuse CML with? Yes, CML can be confused with something called leukemoid reaction. Everything about CML, I think, you know, if I tell you, can you make a list of the things of CML? You'll be like, of course, I know the cause. The cause is the Philadelphia chromosome 922. Is there going to be a spleen? Of course, there's going to be a massive splenomegaly that we notice. There is going to be a massive spleen. Patient comes to you with that dragging sensation in the abdomen. The TLC count is going to be very, very high because it's a leukemia. Does it have basophils? Of course, more than 20% basophils in the accelerated phase. I had studied all these features, you know. But then you have something called a leukemoid reaction. Try breaking the word. Leukemoid. Leukemoid means leukemia-like. Leukemoid means leukemia-like. It's not a real leukemia. It's just leukemia-like. Means it is seen not because of any Philadelphia. Philadelphia is absent. It is seen because of sepsis and infections. Some viral or bacterial infections have caused it. But why am I saying leukemia-like? Because of whatever virus or infection, the TLC, the blood counts have gone high. They are not as high as CML, a cancer, but the blood counts have gone high. Blood counts are higher, you are getting a little worried. Does this patient have leukemia? But no, that patient doesn't have any splenomegaly. That patient is not showing you any basophils. Only just because his blood counts are high doesn't mean he's had CML. Other findings are not there. There's no Philadelphia, there is no spleen, there is no basophil. It's just an infective etiology. Please remember that. But if you still get confused, there is something coming to your rescue called the lab score. Remember, lab score is decreased in CML and it is increased in leukemoid reaction. So now we actually need to understand a lab score. Let's go ahead and talk about a lab score. So first you need to know what is the full form. Either you call it LAP or you call it NAP, but what is the full form of this? So see, the AP means the same. AP refers to alkaline phosphatase. AP refers to alkaline phosphatase. Now whether you call it L, so that would become leukocyte alkaline phosphatase, or you call it N, so that is going to be neutrophil alkaline phosphatase. Repeating, either it is leukocyte alkaline phosphatase or neutrophil alkaline phosphatase. I have understood that the enzyme that I am measuring is alkaline phosphatase and the cell inside which I am going to measure it is going to be neutrophil. So let me tell you, the normal lab score is between 40 to 100. The normal lab score is 40 to 100. So they will ask you, what are the situations in which the lab score is going to increase and what are the situations in which it decreases. So let me tell you guys, think logically. If you're counting a neutrophil, think of all the disorders in which neutrophil count goes up. Because if the neutrophil count will go up, automatically the lab score will also go up because the lab score is being counted in neutrophils only. Okay, so for that, we have a mnemonic called lakes and ponds. What is lakes and ponds? So firstly, the L is going to be for leukemoid reaction. L is going to be, or lakes is going to be for leukemoid reaction. P is going to be for pregnancy. Next, oral contraceptive pills. Neutrophilia, and obviously neutrophilia means any kind of sepsis that is happening. And lastly, in babies with Down's syndrome. So try to analyze the lakes and ponds that we studied right now. Try to analyze that. So firstly, the lake stands for leukemoid reaction and the pond stands for pregnancy, OCP, neutrophilia, Down syndrome. So we have increased lab is seen in lakes and ponds. It is seen in lakes and ponds. Think logically. In leukemoid, it was an infection. Neutrophil count goes up. Neutrophilia and sepsis, of course, neutrophil count goes up. Pregnancy, physiologically, neutrophil count goes up. And even in OCP and usage and Down syndrome babies also, the concept is the same. Neutrophil count will go up and the lab score will automatically go up. But when does it go down? Remember, it goes down in case of CML and PNH. CML and PNH. Many a time students get confused that out of CML and leukemoid, where was it decreased, where was it increased. I've already told you the logic that in leukemoid reaction, obviously it's a case of sepsis. Neutrophil count will go up, the neutrophil alkaline phosphatase will also go up. But just in case you forget this logic in the paper, remember in CML, everything tends to, if I had to read this like an English word, how would you read CML? You would read CML as small. CML would be read as small because I have learned that CML shows you small lab. Shows you small means there's going to be a decrease in the lab score. What was the normal lab score? The normal lab score was 40 to 100. CML shows you a decrease. Even PNH shows you a decrease. And this is what a lab score looks like. This blue color stain that you have over here. You can very well see these are different neutrophils and you have blue color stain inside it. That is the neutrophil alkaline phosphatase. Another thing that I want to tell you, not only did I study CML is small, so there are two small things that CML has actually. One small tells me that it has a small lab score. Basically, it has a decrease in the lab score. But then there's another small, the first sentence of CML that I taught you. Is that Philadelphia problem only pertinent to WBCs or is it going to be a kind of a disorder which has a stem cell problem and it's going to affect all the lineages? Yes, all the lineages. So that means even the megakaryocytes are affected. There are small megakaryocytes which are known as dwarf megakaryocytes. CLL tends to show you dwarf megakaryocytes. So right now, if you've not read the platelet chapter, you might not know. So I've got you for comparison. This is a normal megakaryocyte with so many lobules. So a normal megakaryocyte is going to have so many lobulations in the nucleus. Whereas look at what has happened to a dwarf megakaryocyte. It's become chotu. It's become a tiny little dwarf over here. Compare the two. The nucleus is also just one lobe. It's not multiple lobe. It's become a chotu little thing over here. That is a dwarf megakaryocyte, which they love asking you in your platelet chapter, which disease shows you dwarf. So remember, CML shows you everything small. Lab score is small, megakaryocyte is small. Which wraps up our CML for us, but we are ready for some questions right away. There's a 49-year-old male who comes with sensation or complaint suggesting acute febrile illness. Peripheral smear, read this carefully, is taken which revealed hyperleukocytosis, means WBC count is high, left shift in granulocytes and increase in basophils and the platelets. Yes, increase in basophil, leukemia coming to my mind, CML of course, and of course there's a shift to left, there's a full garden party appearance that is going on. Along with garden party, I can also call this the college girl appearance that is going on. Yes, everyone sorted? Moving on to one more question and we wrap up leukemias. Which of the following statements mentioned below regarding CML accelerated phase is incorrect? CML accelerated phase, tell me. Was it showing you response to therapy, non-responsive to therapy, whether it is spleen or whether it is platelet count? Is this true? Yes, nothing is responding to therapy. Does it show you blast 10 to 19%? Yes, I had three phases: chronic, accelerated and blast crisis. Blast were less than 10% here, 10 to 19% here, and 20 or more than 20 here. So in accelerated phase, of course, blasts were 10 to 19. But were basophils 10 to 19? I kept telling you, they love to confuse you between blasts and basophils. Basophils are more than 20%. So this was the false statement.